who's the consultant physician at this hospital, Pimbura. She graduated from the Faculty of Medicine, University of Periphery, with a second-class honors in 2002 and completed the MD in 2010 from the University of Colombo. She obtained the MRCP UP in 2014. The topic that she has chosen for today is recurrent urosepsis followed by sterile pyuria in a diabetic patient. Quoted Dr. Jayathilaka.
Thank you, sir. I would first like to thank College of Physicians to give the opportunity to present this case. This is actually I have managed not at Pimbura at base hospital Udukuma when this is my first appointment at Udukuma in my proper appointment in 2017. I'm discussing the patient with recurrent urosepsis followed by sterile pyuria. It's a patient with diabetes. My patient is 72-year-old male patient who with diabetes and hypertension from Nakyadenia, which is about in between Karapiti and Udukama, Nakyadenia. He's a father of 4 daughters and son, and he's a from a middle class family. And he was a businessman, but when he was 76, he was active and he was doing some gardening. And when he came to me, he was really active person before the onset of symptom. He came to me with fever, loss of appetite, and urinary tract symptoms, some low urinary tract symptoms with dysuria and some low abdominal pain. He had been treated by GP with antibiotic about 1 week prior to the admission. And because I think it would be not once, but several, because his symptoms are not subtle, with fever about more than 100 and with his pulse rate of 84 and BP little bit high. On examination, this patient generally little bit ill, and there was some suprapubic tenderness and mild renal angle tenderness. So we have done this basic investigation. WBC was 19,000 of neutrophil 86% and hemoglobin 10.8 with platelet 109 with NCRP was 156. Creatinine was 1.46, which was high. It's having more than 10 years, but the serum electrolytes were normal. UFR PTL. And meanwhile, we have started antibiotic IV coamoxiclav 1.2 gram 8 hourly. And his appetite was not that good. And also his CBS level up and down. So we have stopped his oral hypoglycemics and start soluble insulin TTS dose and input output chart maintained. And we have given some IV fluid because his appetite was not that good. s- Right. Then we got the urine culture, that is ESBL coliform. It's been extensive spectrum of lactams, and it was sensitive to cefotaxime, meropenem, imipenem, and gentamicin. So we have switched our IV coamoxiclav to cefotaxime, and we have continued for 7 days. And in the third day of infection of IV cefotaxime, patient symptoms improved, and WBC and neutrophil came down, and CRP improved, and renal function remained stable. Meanwhile, we have done the ultrasound scan as an involved patient, and kidney was almost normal but below normal size, and evidence of evidence of CKD. But there's no obvious evidence of pyelonephritis, but there's a prostatomically with residual volume 156, which is significant. It is for normal person, it should be less than 50 or less than that, but 156 is significant to this age. Then we have discharged the patient after completion of antibiotic. Again, patient came to us in about 3 weeks after from the second admission. And again, he developed loss of peptide lethargy and increased frequency with mild fever. And we redo the UFR. It again came positive with with high WBC with neutrophil leukocytosis. According to previous urine culture, we have restarted IV cefotaxime, and we have sent another urine culture and ABST to Karapiti. And repeat culture again came as same as previous with the SBL coliform with same sensitivity pattern. Then patient's symptoms improve after 4th day of IV antibiotic. WBC and CRP normalized within 7 days. Anyway, we have continued our antibiotic for 10 days to make sure that we have adequately treated the patient. Then meanwhile, we have made the urology referral to Karapitiya urology unit, and after settling the second infection, they have arranged the flexible cystoscopy, and they have found on some thickening intima of the wall, and they have planned send the PSA, which just came as normal range up in few weeks time. And they advise us to start tamsulosin and follow up in the our normal medical clinic for diabetic and monitor the renal function and SOS review from them if there's recurrent infection. Then once patient was asymptomatic, and its sugar control was apparently all right. But again, after 2.5 months, patient present to us with with moderately high grade fever. And again, we have started antibiotic according to the previous culture, and we have recently culture for ABST, urine culture for ABST, and patient symptoms was not improved with IV cefotaxime. Anyhow, we have got down this urine culture in 3rd day over the phone. It mentioned that urine culture again ESBL but resistant to cefotaxime. In this time it was sensitive to only meropenem, amikacin. And meanwhile his renal function also got worse. He developed AKI. So we have started meropenem with renal dose adjustment. and his symptoms was improved, and basically renal function came down to almost his baseline, and we have treated with 7 days of IV antibiotic, meropenem, and total the 10 days of hospital admission, and we have discharged the patient and made the clinic follow-up. In the subsequent follow-up, patient remained urine cultures. We have repeat urine culture after third admission was negative, and it's been coming to our clinic, and UFR was almost all right. Patient asymptomatic. About he was apparently well for 5 to 6 months after the third admission with IV meropenem. Then mid of September 2018, again he came to the clinic with loss of peptide lethargy with the increased frequency of urine without significant fever. He was not that much ill to get admitted, but so we have arranged the investigation as outpatient, and again UFR become positive for moderate feel good with few RBC, but now full blood count it's normal, and CRP was slightly high. The urine culture was this time was no growth, and creatinine was 1.9. Anyway, because of the patient was symptomatic, we have given trial of meropenem for 5 days, and we have done this WBC and CRP. It was normal, and patient symptoms somewhat improved, and because it's the clinical markers came to normal, we have discharged the patient, and we have planned to do the urine culture after 1 week of antibiotic. Then we have arranged several urine culture in few weeks apart. So in that case, all the urine cultures came as negative, but patient symptoms was persistent lethargy, loss of appetite, non-specific abdominal pain. So it's basically it's become very inactive, and ESR was varying from its but from it was went from 76 to 100, more than 100, and we have arranged a chest X-ray, and meanwhile we have done the melioidosis antibody to make sure that we are not dealing with the melioidosis, because with the background of poorly controlled diabetic, and we have sent a sample to Faculty of Medicine Colombo, and 2 samples titer was came as 1 in 40, which was negative. Now we have several problems which is encountered. Patient remain is symptomatic for basically low urinary tract symptoms with loss of appetite, and we got several cultures become negative, and so we got sterile pyuria, then persistently high ESR, and unsatisfactory blood sugar control, and it was varying from hyper to hypo because his appetite not good, he's not taking the proper diet, sometimes he's on liquid diet, so his blood sugar went up and down. So we had the suspicion of whether we are dealing with renal TB. We have referred this patient to chest opinion teaching hospital Karapitiya. They have arranged Manto test, arranged early morning 3 sample for acid pass bacilli and urine PCR, urine TB PCR. So chest X-ray came normal. Manto test was strongly positive, which was 22 millimeter, and 2 samples of TB PCR became positive. But we didn't get the urine culture. We didn't wait for urine TB culture. So we have had a discussion among over the phone by myself, the microbiologist at Karapitiya, and the chest physician, and we have made a decision that we have to start anti-TB treatment on this patient with all the clinical background and available test. We have, so anti-TB treatment started from teaching hospital Karapiti and managed to continue for 6 months. Outcome after TB treatment, his symptoms, which was worried, was appetite and dysurinary symptom, disappeared in a few weeks' time. He developed some short-term and long-term complication of anti-TB but anyhow, we have managed to continue the treatment successfully for 6 months. Because he had very good family support, so it was help us to continue all the all the investigation appropriately and continue the medication, because they had his family members had good rapport with us regarding the management. So problem after the anti-TB treatment, patient developed some feature of depression. It could be attributed to because of his basis long-term illness, which was suffering almost 1 year in between antibiotic and this TB treatment, and also because he's said to be 70 weeks, he worried that it is not it's a black mark to the family, and also worried that it will transfer to his grandchildren. So all the factors was there, and he became a little bit depressed. And so that problem actually we have managed with our psychiatric team with the short course of antidepressant and mental rehabilitation, and we have this continuous talk with the family member and educate them, and we were able to overcome that problem. And also, meanwhile, he developed version of the peripheral neuropathy, which was there before the TB treatment, and difficulty of walking because of the problem with the myopathy with poor nutrition. And so then basically he became wheelchair bound after the treatment. Anyhow, they came to us again. We have given some vitamin supplement, physiotherapy, everything was nicely continued in the hospital as well as at home. So finally, he was able to walk without support, and in few months, he was able to do his normal day-to-day work as before. So I would like to discuss about causes for sterile pyuria. There are several. It can be due to sexually transmitted disease like gonorrhea or viral infection, reaction to some medication, and genitourinary TB, parasitic infection, kidney stone, renal tumors we had to suspect, or renal cyst, or intestinal cystitis, or due to autoimmune diseases. And treated urinary tract infection within 2 weeks with antibiotic, the UFR will be positive and the urine culture will be negative, or even after inadequate treatment, you will get the positive UFR with the negative culture. Also, it could be due to some physiological changes like menopause and pregnancy in female. Then we will just discuss something about genitourinary TB. It is second common cause for extrapulmonary TB. When we consider extrapulmonary TB, the second common site for the bacillus to go and infect. So it accounts about 20 to 40% of extrapulmonary TB. The common bacteria, as usual, Mycobacterium tuberculosis, but rarely you may get infected by Mycobacterium cancersi, Microbovis, so avium intracellular. So when you come to the risk factor of genitourinary TB, immunosuppression it's either due to any other illness, either due to malignancy, so chemotherapy, and diabetic will say it is risk factor, then hypertension, swelling of the kidney for some other reason, calcium deposits in the kidney, or an end-stage renal failure. So when we just come to diabetic and TB, why it's increased risk of TB, usually the patient with diabetes, there's a 2 to 4-fold higher risk of getting TB. It could be pulmonary or it could be extrapulmonary. 30% of patients with TB get diabetics, or it maybe we have patient with diabetic, we get detected to have TB, or when the patient we are detect TB, they may get, when we are further investigation, we will diagnose to have diabetes. So in diabetes, what will happen is it will impair the cellular function due to several reasons, and also because of the hyperglycemia, because of high serum glucose level will affect the cytokine function. So all the things, also poor nutrition, everything will contribute to the poor immunity, which can precipitate the TB in patient. So basically, genital TB is spread by hematology. So almost 99% hematological is spread. Rarely it can be sexually transmitting from male to female, where the external genitalia affected by in the male with discharge in sinuses. Rarely can it go from male to female. So it's just to show that basically that how the organism comes to the lungs, and it will stay as a latent form, and when immunity is suppressed, it will reactivate, and it will go to extrapulmonary organ, bones, pleura, lymph nodes, central nervous system, genital system, to kidney and testes and ovaries. So just to explain how you get the infection from lungs and how you get activated in the kidney. When you get the infection in the lung, that primary complex or conformis, it will stay as a dormant form, and it will become active when your immunity has gone down. Then it will break into the capillaries and will go spread to the through the blood to the kidneys. Initially, that bacteria go and lodge in the periglomerular capillaries, and it will stay there and cause local granuloma. But if the patient, if immunity is good, it will stay like that as a latent form, or it will clear itself by your body immunity. But if your immunity drops, it will reactivate and further grow, and it will rupture and go down your rest of the collecting system. So when the TB bacilli, it stays in the periglomerular capillaries, and then it forms periglomerular granuloma, and it will expand with caseous necrosis and form cortical abscess, and it will rupture into pelvic system and will cause pyuria. If it is initial stage, if you got what you get this pyuria, only you are getting some urinary symptoms like dysuria and increased frequency. So this is to show you what is happening in your genitourinary system with the TB infection. So that the cortical abscess will, it can be, so it can break into the calycis system or collecting system, or it can break out for the perinephric area, which is not actually mentioned here. So you can make the abscess in the perinephric region, or it can break into the calyces, and those stuff go in lodge in the calyces system or PUJ. So it will cause PUJ obstruction and will cause hydronephrosis. In the kidney, this cases material form in different sites. Ultimately, the whole kidney will got distorted, and calcium deficits will be happen in the for the further process. And ultimately, almost the kidney function will get affected. So you will get autonephrectomy following the advanced disease of renal teeth. When it's come to the ureter, it will go down the ureter and it will affect the ureter internal layer as well as the outer layer, will form strictures, and it will cause the hydroureter. And when it's come to the bladder, it will damage initially the intima, and there was some only inflammation around it. But when the disease get advanced, it will affect the bladder wall muscles and cause scarring and cause contracted bladder. So presentation of the TB is most of the time you won't get the typical signs like the fever, hematuria, increased frequency is the typical feature with fever, but it's not the common presentation. So most of the time you are getting the chronic symptoms, loss of appetite, and intermittent symptoms of dysuria. So it's basically non-specific. So you had to have more weight on suspicion to diagnose the disease, because most of the time it looks like something else. So basically we can do the arrange the investigation, simple count, ESR, and chest X-ray. About 50% of cases normal. So we don't most of the time we are not getting any clue, like the patient I have present to you. And skin Mantoux test will be positive. And early morning urine for culture for acid-fast bacilli, it is the sensitivity 65%. So almost 45% will be negative. So most of the time it may be not helpful, but if it is positive, yes, it is 100% specific. Having 100% specificity. Then we come to the nucleic acid amplification test. You can get the results within 2 to 48 hours, and either from polymerase chain reaction or ligand chain reaction. For WHO recommended to do that PCR expert MTV test, which is urine. For urine, it's sensitivity to 83 to 95% and specificity to 79 to 99%. So in the simple X-ray KUB, 50% of cases in advanced disease, you can get some evidence of TB by calcification. You can see the calcification and distort renal kidney and some calcification in the ureter. Then if you're going CT KUB is one of the investigation we can do early, but we have not arranged, we have not planned to do the CT because his renal function was not good. And so we don't want to compromise his renal function by giving contrast. So, initial stage, you can see mural thickening and enhancement and early capillary necrosis, and late stage multifocal stricture and some hydronephrosis in CT. Ultrasonography, actually, it's not helpful in initial stage, it's almost normal. But in advanced case, you can see that cystic lesion, cavitation, and cortical scarring and hydronephrosis and abscess formation. So intravenous pyelography is the gold standard treatment for renal TB. Only 10% patient will get negative results. So almost 99% patient we can having a positive result with help for diagnosis. So initial stage you can, initial stage of renal TB, you can see the early finding that irregular calyces, moth-eaten calyces, which is in the top part of that picture. So here, and phantom calyces mean your calyces system you can't see with this contrast medium. This disappears. You can see it's called phantom calyces, then hydronephrosis, and in the lower urinary tract, that's curlicking signs, which is here where the infection involving the Pyuria and it will spread to the rest of the surrounding tissue and which causing the that upward movement of the ureter, which mentioned as curling signs, which was initial urologist has mentioned. This was mentioned that it's that is given that name for that, and sawtooth ureter and beaded ureter. So management is basically, it's simple, not like the confirmation of diagnosis. It is basically rifampicin, INH, pyrizinamide, and ethambutol for 2 months, with followed by rifampicin, INH for 4 months, for total of treatment for 6 months for the normal patient. But patient with severe immunocompromised or patient with HIV, the treatment should be extended up to 9 months. But the advanced cases, you may need to get the your surgical opinion and intervention for hydronephrosis, hydroureter, or infected kidney. So that is the regarding the renal TB. So I would like to thank the people who helped me to manage this patient at base hospital Udugama, which was B-grade hospital. With we are having the basic facilities is X-ray and ultrasound and laboratories. Basically our medical team and now physiotherapy in our hospital and radiology unit, and also teaching hospital Karapiti gave me a big support for most of the cases which I managed there. And this patient that my consultant microbiologist and chest physician helped me to manage this patient a lot. So, and finally, the family members have done the big role in this management, because they are the one who is bringing the patient and continuing the treatment and had a good rapport with us. So, so I would thanks for them. Finally, I thanks for all of you giving the opportunity to me.
Thank you, Dr. Samanthi. Thank you for bringing this excellent case and discussing it here. So, sterile pyuria is something that you encounter in your day-to-day practice in the wards. So, as you say that you have to think of TB, most of these, say, all of these cases, we are impressed that one of the different diagnoses is TB. And for the young budding consultants, you see that you need not be in a nursing hospital to service to the people. Someone is a good example of that. She has been at Pimbura and they announced it's at Pimbura. But with good support from the people at nearby hospitals, she's doing a good service, and we expect the same from you when you graduate, when you get your qualifications and come back. And thank you very much again from the College of Physicians.
Process for sterile pyuria. Paracetamol. No, aminoacetylcholine is paracetamol. How does that? Well, you have put some forces for sterile pyuria.
Yes. Unfortunately, Pradeep, we'll have to get that answer out of the podium. Say, we have to take time. We'll have the chat during the lunch hour.
Thank you.
We need to give you something.
Yeah.
Later.
No, I understand.
Thank you. Next speech is by Dr. Khan Kaviratan. He is the Permanent Secretary of the College of Physicians. He is a consultant nephrologist graduating from the Faculty of Medicine University of Canada in 2012 and completing the MD Medicine in 2018 from the University of Colombo. Dr. Kaviratan obtained MD University specialty graduating nephrology in 2019 and been postgraduate diploma in renal and pancreas transplantation from the University of Netherlands in 2020. Obtained his MSc transplant medicine in 2021 and received MRC UP qualification in 2023. Also completed 1 year fellowship in renal pathology and other 1 year fellowship in pulmonary practice. The topic he has chosen for today is acute peritoneal dialysis in patients with dengue hemorrhagic fever. That's a great topic. Okay. We would be struggling in this sort of patient.
Good afternoon.